Hello students, this is Dr. Ways and welcome to your lecture on the abdominal wall. So to talk about the abdomen and the abdominal wall, we first have to know what the boundaries of the abdomen are. So superiorly we have the diaphragm, and notice that that overlaps to some degree with the thoracic cavity, so the abdominal cavity would be in the middle underneath the diaphragm, whereas the thoracic cavity would be to either side. And then you have the muscles of the abdominal wall forming the anterior boundary, the spine, and the posterior abdominal muscles forming the posterior boundary. And then there's a boundary here that's imaginary. There's no physical thing there separating the abdominal cavity from the pelvic cavity. Sometimes they're considered together as the abdominopelvic cavity, but if we're strictly talking about the abdomen and the abdominal cavity, the boundary here would be this imaginary line between the pubic bone and the sacrum. Then, of course, the lateral boundaries would be the abdominal wall muscles as well. And again, this is just showing you the boundaries with different pictures. You have the anterolateral, and when I say anterolateral, they're referring to the anterior part moving into the lateral aspect. And then the posterior, which would be back here, and of course that is going to be your vertebral column as well as the muscles here that we'll talk about as we move along with excuse me, the abdominal cavity. So the abdomen can be divided into regions as you're looking at it from the anterior side of your patient, if you will. All right. The first way we can divide it is into quadrants. All right, and the quadrants are here on the right. So remember, when you're looking at anything anatomical, you're going to assume that it is a person that is facing you. So everything that is on your right is their left, and everything on your left is their right. So up here you would have the right upper quadrant, left upper quadrant, right lower quadrant, and left lower quadrant. And you can abbreviate them RUQ, and so on. And notice that when you divide into quadrants is that we're using something called the transumbilical plane. All right, so the line is across the umbilicus, and we refer to that as the transumbilical plane, along with the median plane. All right, right up the middle of the body. So that will divide the abdomen into 4 different quadrants. Now, if we look on the other side, on the left here, we have the abdomen divided into regions instead of quadrants. All right, and there are 9 regions that you should be aware of, and the lines that make them up, or the planes that make them up, would be, again, we see this coming up, the midclavicular planes coming down from the clavicles all the way down to the pelvic region here. And then we have what we call the intertubercular plane, and it's called intertubercular because it passes along the iliac tubercles. And we'll see what those are later on. And then the subcostal plane. All right, the subcostal plane, notice that is a plane right underneath the 10th rib there. All right, and then what these are called are the right and left hypochondrium. All right, hypochondrium meaning under the cartilage, in particular under the ribs, cartilage of the ribs. The epigastric region, epi means on top of, so gastric stomach, so on top of the stomach. Right here, the umbilical region, makes sense why it's called there, because it's right in the middle, right where the umbilicus is. Left flank, right flank, and the flanks can also be referred to as the right lumbar or right lateral region. Okay, so those are things that may be used interchangeably depending on what resource you're using. And I may use them interchangeably as well. And then down here we have the pubic region in the middle, and then the right groin and left groin. The right and left groin are also known as the inguinal regions, so right and left inguinal regions. All right, so aside from knowing what these regions and what these quadrants are that divide up the abdominal cavity, the reason we do that is so that we can identify easily, like let's say a patient comes in with a problem and we need to identify where that problem is located. This is an easy way to identify where the problem is and identify what might be wrong based on what we know is in those regions. So I want you to start getting a feel for what organs are in what quadrants and what organs are in what regions. And when you do the physical exam in clinical correlations and next semester, you'll definitely be utilizing these terms to facilitate your exams. This is just another picture showing you the planes that we talked about on the previous slides. Again, to point out the midclavicular planes. And then the subcostal plane, which can also be referred to as the transpyloric plane. Right, transpyloric plane, because that would be where the pylorus of your stomach would be located. And notice that that is at the level of about lumbar vertebrae 1. The transtubercular plane is also the intertubercular plane, same name or different names for the same plane, and that's at the level of about L5, just to give you a reference to where it is in the body. And again, we already mentioned the midclavicular planes. So the previous slides would be your surface anatomy, like we've done with previous lectures, showing everything that you would be able to see with the skin. But now we're going to go a layer underneath and talk about the different fascia that you will run into. So the first type of fascia that you'll run into is the superficial fascia, right underneath the skin, also known as Camper's fascia. And if you look at it, there's a bunch of adipose tissue there. So just like we saw with the thoracic wall right underneath the skin, you'll see the similar type of fascia with a lot of adipose tissue buried within it underneath the abdominal wall. The other type of fascia that's just underneath the superficial fascia fatty layer would be the superficial fascia membranous layer. So that would be this membranous layer right here. You can kind of see it in white right here. Not this part right here, but the line that's directly connected to the fat right here. So up to that point where I just drew, that would be the superficial fascia membranous layer, also known as Scarpa's fascia. So from a side view here, you see the Camper's fascia versus the membranous fascia, which is this little line right before the white space there in this picture as well. And then the muscle behind that. So skin, Camper's fascia, membranous fascia, and then the muscle. And where there's not muscle, you have these aponeuroses, which are connective tissue connections between two regions of muscle. If you remember, tendons connect muscle to bone, ligaments connect bone to bone, and aponeuroses connect muscle to muscle. And so you'll find these aponeuroses behind the fascia associated with the muscle. And then down here we see the membranous layer of the superficial fascia without the Camper's fascia in front of it. And on this side we see the aponeuroses underneath. So you can clearly see that they are distinct layers from one another. And then of course the muscle would be here. And the muscle and this aponeurosis would be lying on the same plane, and again underneath this superficial fascia. All right, so some more surface anatomy. Again, we have our median plane. What they're calling here is a sagittal plane. Recognize that those pretty much mean the same thing. And then you have your transumbilical plane. Notice that's going right through the umbilicus. All right, so what that tells you right away is that we're dividing the abdomen into quadrants here. And if we take a point from the umbilicus along the transumbilical plane and go at about a 45-degree angle, 2/3 of the way between the umbilicus and the anterior superior iliac spine, which you should be able to find on your patient or yourself, we'll have McBurney's point, which is a approximate location of where the appendix is. So if there is tenderness at that point, or if you're doing a palpation, rebound tenderness at that point, that could be an indication of appendicitis. So an important landmark to keep in mind, surface anatomy that's associated with appendicitis. So getting a little more specific, we're going to divide the abdominal wall into different sections, and we're going to start with the anterolateral. And by anterolateral, we mean everything that's in the anterior moving to the lateral side of the abdominal wall. In fact, we're going to go up to about right here. All right, so we're going to start on the outside again with the skin. All right, and then under that, which is also referred to as your subcutaneous layer, we'd have the fatty layer called Camper's fascia, and underneath that, separating the muscles from Camper's fascia, would be the membranous layer or Scarpa's fascia. And just as a preview to what we're going to be talking about, the different muscles, here would be a muscle right here. Here would be a set of three, 1, 2, 3, going from external to internal, or superficial to deep. And then the aponeuroses that connect muscles together. All right, so notice in this picture we have the skin and the fascia stripped away. So we're starting with the most external of the anterolateral abdominal wall muscles, and that would be the external oblique muscle. External oblique, external meaning most outside, oblique because they're running at an oblique angle. Notice the direction the fibers are running. I like to say, and I'll probably show you this in lab, that the directions are running in the same direction as if you were putting your hands in your pockets. So the external oblique runs in an oblique direction as if you're putting your hands in your pockets. All right, and then connecting the right and the left external oblique muscles is the aponeurosis of the external oblique. So it's a sheet of connective tissue that's connecting the two external oblique muscles. And underneath that, and this aponeurosis is also connected to this, you'll find the linea alba, which is a white band of connective tissue. Linea meaning line, alba meaning white. So white line of connective tissue running right down the middle of the abdominal wall. As far as the information over here in this table goes, this comes from your bare bones workbook. I'm not going to be as concerned about the origin and assertion of where these muscles are, but they will give you a good idea of what they're connected to. But do know the action of these muscles, what they provide in general to the abdominal cavity. And we'll talk about the innervation as we go along, specifically for the anterolateral muscles and then for the posterior muscles. Deep to the external oblique, and I'll just outline the external oblique in blue here. Deep to the external oblique, and of course you can see the aponeurosis of the external oblique that's cut away. And we'll see underneath that the internal oblique muscles. Again, oblique meaning running in an oblique direction. And notice that these fibers run in different directions. Superiorly, they're running upwards towards the midline of the body. Then they reach kind of a transverse direction, and then they run in the same direction as the external obliques that are on top of them. The hands in pockets kind of scenario. Notice that the internal obliques also have their own aponeurosis, which then connects here at the linea alba. And their action is the exact same as what you'd see for the external obliques, as well as the innervation. And then the last layer of muscle in the anterolateral abdominal muscles, as we're talking about anterior to the lateral, not directly down the anterior of the abdominal wall, would be the transversus abdominis, And you notice that all the fibers tend to run in one direction, which is transverse to the sagittal line of the body. And again, the transversus abdominis will also have its set of aponeuroses. All right, so now that we've gone through the 3 layers of muscles that are more or less on the lateral side of the abdominal wall, the aponeuroses of these come across each other and are covering what we know as the rectus abdominis, which we'll cover in the next slide. And the rectus abdominis, of course, is separated here by the linea alba and as well as tendinous intersections between them, which also connect to the aponeuroses of the lateral muscles. But in somebody who has very low skin fat, we can actually see the outline of some of these structures in the abdominal wall. So right here you would see here you would see the 2 sides of the rectus abdominis, the linea alba, the tendinous intersections between each one of them. Of course, the muscle in between each one of those would form what we refer to as the 6-pack abs. And then you can see the muscles here on the side, which would represent the 3 layers, the external obliques, internal obliques, and the transversus abdominis. All right, and the border between where the obliques end and the transversus abdominis ends and the rectus abdominis begins would be called the linea semilunaris, or semilunar line, since it kind of has this curved appearance to it. And of course, you can see that here on the picture as well. All right, so the rectus abdominis, taking a look at it, we've stripped away all the aponeuroses of the external obliques and transversus abdominis. We still see the linea alba, which is a point of connection between all of these muscles, and then those tendinous intersections. And notice that the fibers of the rectus abdominal muscles move in an up and down, or superior to inferior direction. And so that means when they contract, what this is going to cause is a flexion of the trunk, allowing you to flex your trunk and bend over. All right, and considering the aponeuroses of the oblique muscles that cover the front, and you can see in this picture right here, cover the front, and then a sheath of connective tissue that's behind the rectus abdominis. Together, those make up what we refer to as the rectus sheath, or in other words, a sheath of connective tissue that is surrounding the rectus abdominis muscle. But one of the things I want you to notice about the rectus sheath is that the rectus sheath only goes down about 2/3 of the way from the top of the abdominal cavity, or superior end of the abdominal cavity, to the inferior end of the abdominal cavity. And then it stops. And then underneath that is a transversalis fascia, which lines the inside of the entire abdominal wall. And so that line that's formed between the end of the posterior wall of the rectus sheath and the transversalis fascia, which is inferior to that, is called the arcuate line. All right, the arcuate line. And so you can see that in these pictures right here. Here's your transversus abdominis aponeurosis going underneath, or behind rather, the rectus abdominal muscles and coming out. And then this green represents the transversalis fascia. All right, and you can see that right there underneath the rectus abdominis muscles. But as you get below the arcuate line, you notice that the aponeurosis of the transversus abdominis joins with the other aponeuroses to form the anterior portion of the rectus sheath, and there is no rectus sheath between the rectus abdominis muscles and the transversalis fascia, which we see in green here. All right, so that is just a dividing line of where that aponeurosis, or that posterior wall of the rectus sheath, ends. And then right underneath that transversalis fascia, you will have your parietal peritoneum, and your abdominal organs. So as we get down lower into the abdominal cavity, reaching towards the pelvic cavity, there's actually less protection, if you will, between what's on the outside of the um, abdominal wall and the inside of the abdominal wall. All right, as far as the blood supply to the anterolateral abdominal wall, remember these internal thoracic arteries right here would be on either side, and that splits off into what's known as your superior epigastric artery. All right, epi meaning on top of, gastric meaning the stomach. So literally, your stomach would be right here, and those would be on top of it, and as well as your musculophrenic artery. And you notice that the musculophrenic runs along the coastal border of the ribs, the coastal margin of the ribs, and towards the lateral side of the abdominal wall. All right, and then of course they split and branch out. You don't need to know all the branches to that. But what I do want you to realize is that coming from below, in fact, these are coming from the external iliac artery, you have two branches. One would be your inferior epigastric artery, and those are branching upwards. In fact, let me do those in a different color. Those are branching upwards. We'll do those in blue. And your deep circumflex iliac artery, coming upwards, right, and then branching off. So you have arteries branching from up superiorly and arteries branching inferiorly, and they'll connect at spots with each other. And what we call those are anastomoses. And the point of anastomoses is to connect two major blood supplies. In fact, here you'd be connecting the uh, subclavian arteries to the external iliac arteries through all of these branches. And that forms kind of alternative pathways for blood flow just in case a major pathway happens to shut down. So these anastomoses ensure that your abdominal wall has an adequate blood supply, even in the face of an inadequate blood supply by other pathways. For example, if there happens to be an aneurysm in the aorta and you're not getting blood supply down to the lower part of the body, since these upper uh, tracts come off of the subclavian artery, in fact, the internal thoracic artery comes off the subclavian artery, you're still going to have an adequate blood supply to these areas down below because of the connections between the inferior and superior arteries. Another important consideration is that the inferior epigastric artery, as it runs up, it branches out into branches that go superficially to the rectus abdominis and also posterior to the rectus sheath. All right, and given where its location is and where it's heading upward towards, it's going to be an important consideration during abdominal surgery that you don't want to accidentally nick that area. So it's important to understand, especially if you're going into surgery, where these major arteries are located and avoid them. Continuing on with the anterolateral abdominal wall, we want to be aware of the layers that are underneath those abdominal wall muscles. All right, so we talked about the skin, the superficial fascia, the muscles in their aponeuroses. Just under the aponeuroses, you have, we've already seen the transversalis fascia, and you can still see that in green here, just underneath the aponeuroses. It's hard to point with this pen. Then underneath that, you have your extraperitoneal fascia. All right, extraperitoneal means outside the peritoneum. The peritoneum would be everything that's inside your abdominal cavity. All right, so the extraperitoneal fascia, which consists of your preperitoneal, which would be up front, anterolateral, and your retroperitoneal, which would be back here along the posterior wall of the abdominal cavity. All right, and these peritoneal fascias make up what you know as peritoneal membrane, and just like the membranes, the pleural membranes that surround the lungs and the pericardial membranes that surround the heart, the peritoneal membranes are also a double layered membrane that have two sides. One that is a attached to the wall, your parietal peritoneum, and one that's directly attached to the organs, and that would be your visceral peritoneum. Now, the peritoneal membranes in the abdominal cavity take on some special structures in certain locations, and so we want to talk about what some of those locations are, some of those specific locations are in specific structures. One would be the lesser omentum, and you've probably heard that term omentum before. It actually means apron. So usually when we think of omentum, we think of the greater omentum, and the greater omentum is this apron of fatty tissue that literally just covers the intestines of the abdominal cavity. And so, if we were doing a real dissection of a human cadaver, and I think the anatomage table has a pretty good simulation of that, but I can post some videos and pictures to show you better what that looks like. You would just take this flap of omentum and reflect it over the rest, the abdominal organs, so that you could see what's underneath. All right, so going to the lesser omentum up here, it would be a small apron of fatty-like tissue that's part of the peritoneal membrane system that connects the liver to the stomach. All right, so you'd find it between the liver and the stomach, and it's a really small bit of tissue. And in the anatomage table, we'll be able to find that and identify it. All right, then we have omental bursa, and omental bursa is a small space between the lesser omentum, the liver, and the stomach. So it's basically a hollow space that's formed by the uh, lesser omentum and the organs that surround it. Okay, another big one, the mesentery. If you were to pick up your small intestines and look at them, you'd see that they are connected, all interconnected to each other through this membrane called the mesentery. All right, and if you look carefully, you'll find in the mesentery a bunch of blood vessels that will be carrying blood to the intestines and of course away from the intestines, and we'll see what the arterial and venous structure of that looks like once we get to the organs of the abdominal cavity and kind of take apart the small intestines and see where those blood vessels are coming from and what they're supplying. All right, we also have the transverse mesocolon, which is this little piece of connective tissue right there, or peritoneum right there. That's moving in a transverse direction, of course. And then the greater sac, which is similar to this omental bursa. It's just a potential space or hollow space between the loops of the large and small intestines where you're not going to have peritoneal membranes. And please ignore this little sentence about the Gross Anatomy ebook. It was a resource that we used in the past that we are not going to be using this year. All right, so now we want to consider the drainage of the abdominal cavity. Not the abdominal cavity, the abdominal wall, sorry. And notice that there is, so here would be your axillary vein here, and here would be your femoral vein. And you have this main vein that's going between them. All right, notice that's connected. And all of these pathways that are branching out from that, again, collateral circulation, to just in case either the superior or inferior vena cava are blocked, you will still be able to get drain blood supply from the abdominal wall. Same thing with lymphatics. They're draining in multiple directions. and have redundant flows just in case something gets blocked elsewhere. Nodes you need to pay attention to: parasternal lymph nodes. Remember back to the pictures we showed earlier of the thoracic cavity. There were these parasternal lymph nodes lining the either side of the sternum. We also have our axillary lymph nodes, which are going to drain fluid from the excess fluid from the abdominal wall. Notice that they're coming here. And also superficial inguinal lymph nodes that will be draining fluid from the lower portion of the abdominal wall. As far as nerves go, the dermatome is from T7 to T11. So notice this area right here, T7 to T11, branching all the way to the lateral portion of the abdominal wall. T7 to T11 would be your thoracoabdominal nerves. And you can see these right here on this picture down here. T12 below that would be your subcostal nerve. All right, your subcostal nerve. And of course, that would be down here as well. And then L1 would be your iliohypogastric or ilioinguinal nerves. And that would be these down here. So from T7 down to L1, you have these branches of nerves that are coming from, again, roots of the spinal cord, and then supplying the muscles of the abdominal wall with a nerve supply that will allow them to contract, and also a sensory supply that will allow the abdominal wall to perceive sensations. Hence the note about there being muscular branches and cutaneous branches. All right, so next we want to talk about the inguinal region. And the inguinal region would be the inferior end of the abdominal cavity, where you will have structures related to reproductive anatomy. And so during the development in the male, you have here the abdominal wall, and this would be the external part. You have this structure called a gubernaculum that's attached to the outside of the abdominal wall. And at the other end, it's attached to the testes. And as there begins to form an outpocketing, notice that the abdominal wall muscles are going with this outpocketing that's going to eventually become the scrotum. The gubernaculum is pulling the testes as that outpouching is forming. While that's going on, the gubernaculum is also shrinking, so that by the time that the testes are fully formed, not only do you have this sac that's outside of the abdominal wall, but you will also have the testes within that sac. All right, and we'll talk about how that is structured along with the contents of the abdominal cavity as we move along this lecture. So going here to the adult, you see the internal oblique muscle going down, and it actually becomes part of the muscle that surrounds the scrotal sac, which is known as the cremaster muscle. All right, and it doesn't contract when the internal obliques contract, but it does respond to cold temperatures and anxiety. And we'll talk more about that in physiology. All right, so notice that the outpocketing right here, where the testes and the scrotal sac come out of the abdominal cavity, is the superficial inguinal ring. And again, that is right at the border between the inside and the outside of the abdominal cavity. And then they traverse through the abdominal cavity wall and then have the deep inguinal ring. And so everything that's beyond that is going to be actually inside the abdominal cavity. All right, so the testes, the spermatic cord, go through the superficial inguinal ring, all right, just outside the abdominal wall, through the abdominal wall, and then through the deep inguinal ring into the abdominal cavity, where you'll have the structures continuing on to where they will go. And if it's in the case of the vas deferens, it's going to go into basically the ejaculatory system and then into the urethra. All right, and we'll talk about that once we get to the reproductive systems. In the females, you have something similar going on. So here would be the skin of the abdominal wall, and here would be Camper's fascia. And you notice that there are these rootlets of connective tissue, which was the vestigial part of the gubernaculum. And it will continue on through the abdominal cavity, where the superficial ring would be in males and the deep ring would be in females, and then into the abdominal cavity. But instead of becoming part of the ejaculatory pathway, it will become the round ligament of the uterus. All right, and again, we'll see that when we get to reproductive anatomy as well. All right, so let's look at this region a little more carefully. At this top picture, you see the external oblique. So the external oblique muscles, that means all the most superficial aponeuroses are already in place. And here you can see the superficial inguinal ring. And I'll only do it on one side so that you can see it uncolored on the other side. Superficial inguinal ring with the spermatic cord coming out and going into the scrotal sac. All right, and then they have these dotted lines right here, which is representing the inguinal canal. All right, the inguinal canal through which the spermatic cord is going through. And just for reference, what the spermatic cord is the vas deferens, the arteries, veins, and nerves associated with the testicles and the scrotal sac. So that's what would be within the spermatic cord, or all of those structures. If we peel away one layer, all right, so we have our internal obliques right here, and then the aponeurosis for the internal obliques, we notice that now we've taken away the superficial aponeurosis of the external oblique, and we directly see the spermatic cord that was going through the inguinal canal. All right, so we see it going in right there. And then if we remove one more layer, the transversus abdominis, we notice that is where we see it actually going into the abdominal cavity. And if you look at the transversalis fascia, that's where it's going through the fascia and into the abdominal cavity proper. All right, so your deep inguinal ring would be associated with where it's actually entering the abdominal cavity. So you can see that in the transversus abdominis, and you can see that with the transversalis fascia, and the internal oblique would consist of the actual inguinal canal. All right, so the superficial inguinal ring through the inguinal canal through the deep inguinal ring. Okay, and I may not have mentioned this before, or maybe I did. If you look in your lecture notes and you pull up the notes section of it that's associated with each slide, there's more information about these structures and what their boundaries are and what specifically is in them or makes them up. And a lot of that information comes from a Rare Bones book, but it might help to supplement what you are learning with these lectures. Just FYI. The reason that we talk about the inguinal region in more detail is that a common problem that you may run into as PAs are inguinal hernias. And so I want to give you a sense for what hernias are, what inguinal hernias are specifically, and the difference between a direct inguinal hernia and an indirect inguinal hernia. And this will come up again in your physical exam lab next semester. So make sure you pay attention to the difference between what direct and indirect are. So the definition of a hernia is basically when your peritoneal sac is protruding through the abdominal wall in the groin area or in the inguinal area, hence inguinal hernia. Sometimes organs may come with it, such as intestines, but sometimes they may not. So we'll talk about what the different kinds are. So be aware also that they can happen in males and females. For some reason, the picture of the male hernia did not show up in this slide for the for the lecture, but it is in your PowerPoint presentation if you're following along. All right, so with indirect hernias, an indirect hernia is where the hernia goes through the inguinal canal. All right, so it enters the inguinal ring, goes through the canal and out the superficial inguinal ring. All right, and technically into the testes. And so that is the picture that you're seeing on the left with the male there. That would be an example of an indirect inguinal hernia. Again, it's going through the inguinal canal. Direct inguinal hernias, on the other hand, do not go through the canal. They are going to be pushed through the abdominal wall medially to the inguinal canal. So the reason why they call them indirect is because direct hernias are going directly through the abdominal wall, a weakened area of the abdominal wall, whereas indirect hernias are taking advantage of a passageway that naturally exists through the abdominal wall and going through that instead. So indirectly going through the abdominal wall as opposed to directly going through the abdominal wall, if that helps you remember the difference between indirect and direct. The purpose of this slide is to point out right here the inguinal triangle, also known as Hesselbach's triangle. And this is commonly where the abdominal wall tends to get the weakest and where direct inguinal hernias will occur. Again, notice that here is where your deep inguinal ring is, and here's the inguinal triangle, and here's your pubic symphysis just for reference. And so direct inguinal hernias will actually occur medial to where the indirect inguinal hernias occur. And notice that it's potentially a much bigger space, so direct inguinal hernias may allow for more abdominal contents to poke through the abdominal wall than you would see with a indirect hernia. Indirect hernias, more common in males than they are in females because, well, the reasons for that are debated, but likely because of the bigger size of the inguinal ring and thus the inguinal canal, because you have more going through it, the spermatic cord and all the structures associated with that versus a ligament in the females. And so then that would say that females are more likely to get direct hernias. And then this picture up here is just showing you a gross anatomy of what it would a direct hernia would look like as you're going through here. And take notice of the testicular vessels, so that would be the spermatic cord. Here's where the inguinal ring would be, and notice that this is occurring medial to that inguinal ring. And then here are the inferior epigastric vessels, artery and vein, that we mentioned earlier that are part of the abdominal wall. And so if you're doing a surgery for a direct inguinal hernia, you want to be careful doing the surgery to cut in a very specific place to avoid these vessels. I also do want you to get a sense that inguinal hernias aren't the only type of hernias that you can get. All right, so there are multiple types of hernias. Anywhere there's a weakening in the abdominal wall, where abdominal contents or the peritoneal membrane is poking through the abdominal wall, is a definition of a hernia. So what we've been talking about are the inguinal hernias, direct versus indirect, and this picture is really good because it shows you the difference in the surface anatomy of where they would be occurring. Another type of hernia would be a femoral hernia, and you notice that the femoral hernia is lateral to where the indirect inguinal hernia is, and so we'd be talking about more in this region right here. And actually, if you look at even a little bit closer, femoral hernias are really occurring below that inguinal ligament that between the anterior superior iliac spine and the pubic symphysis. And so femoral hernias are occurring below that, more associated with the pelvic floor. And that's one of the reasons why females are more likely to get femoral hernias than males are, because often due to childbirth, weakening the pelvic floor, femoral hernias are more likely to occur in that region. Other hernias in different areas of the abdominal wall: umbilical hernias, epigastric hernias, incisional hernias, of course, could occur anywhere, but other types. But just to point out that there are other types of hernias that can occur. Incisional, of course, would be associated with surgery, so not something we want to talk about here in anatomy. Epigastric hernias, not as common, and umbilical hernias, also not as common, and usually associated with congenital conditions. And you may talk about that in your clinical medicine class when you talk about hernias. All right, now we want to go into your posterior abdominal wall. And of course, I want to show you one thing right here. Here are your ribs, all right? And notice that the abdominal wall extends along with the diaphragm above where your ribs are located. So anything above this line would actually be protruding, would actually be protected by the ribs, more laterally and posteriorly. And so you see that your kidneys are partially protected by your ribs, as well as any organs that would be up in this region, such as liver, stomach, and so on. So something to keep in mind. Notice I put clinical correlations. It's missing from here again. So look at your regular slide from your PowerPoint lecture. Clinical correlations, that's one of the reasons that I put that there. The other reason is that when you are doing your physical exam lab, one of the things you'll be feeling for are aortic pulsations. And so you want to have a good idea of where the aorta is located. All right, so it's right here, running right down the middle, right where in front of the bodies of the vertebrae. So that would put your inferior vena cava slightly off to the right. Okay, and when you find the abdominal aorta, you should be able to pretend there's skin and muscles around here, palpate and find where the pulses are located, and actually locate where your um, abdominal aorta is, and be able to feel that in physical exam labs. So something to keep in mind, because you will be going into that. So it's a good idea to know why we're doing this class, right? Where the anatomy is and what you're going to be feeling for and where you should be feeling for it. All right. So in talking about so another clinical correlation is that you will be listening for renal artery bruits. All right, and you'll find out what bruits are once you get to physical exam lab. So I'm not going to go into what they are here, but if you know where your abdominal aorta is, just to the left and just to the right of it, you'd listen for your renal artery bruits. All right, so that's important to know that your kidneys. All right, so here would be your about your 10th rib right here. Find your 10th rib, go over. That's where your kidneys would be, and that's right about where, close to midline, your renal arteries would be. All right, other areas where you'll be listening for bruits are in your iliac arteries. So your right and left iliac arteries. So if you know where your anterior superior iliac spines are in your patient, and you go medially, that's about where your iliac arteries are, and you can listen for iliac artery breweries in those locations as well. All right, muscles that are associated with the posterior abdominal wall. Two of them that are important are your psoas minor and your psoas major, which collectively are just going to be referred to as your psoas muscles. And then your iliacus muscle right here. Together, those are going to form what we call the iliopsoas, right? The iliopsoas, your iliacus muscle and your psoas major and minor, iliopsoas. And when you are doing physical exam and you are testing for problems with the abdominal cavity, one of the things that you'll do is an iliopsoas sign. So notice that these two muscles are connected to your femur. So when you do certain maneuvers with your legs and you feel pain in your abdominal cavity, that could tell you that you have some deeper inflammation going on with your abdominal cavity, and your muscles are being affected by that. The other muscle that you'll find in the posterior abdominal wall is the quadratus lumborum. Quadratus lumborum. Named so because it has a quadrangular shape and it's in the, notice the lumbar region right here. As far as all of this information right here in this table, I pulled this from your textbook in Clinical Key, Gray's Anatomy for Students. It's not in your bare bones workbook. So it's good information to have to help you understand where these muscles are located and what they're attached to and what their function is. However, you will not be tested on any of this information as it's not coming directly from your bare bones workbook. But the information about the muscles themselves, important, especially as we've said, because it has a direct clinical correlation, which we will see next semester. All right, the other posterior abdominal wall muscles, of course, would be those that are part of the diaphragm. All right, so I'm outlining the diaphragm right here, ignoring the central tendon because it's not a muscle. So again, the diaphragm. And what I want to point out about the diaphragm are the right crus and the left crus right here. Right crus and the left crus, which form the borders of what we talked about earlier, the abdominal hiatus or aortic hiatus, where the aorta goes through, and also the, if you see this green right here, the lymphatic trunk. Okay, right here. So those are going to mark the boundaries, and notice that they are attached to lumbar vertebrae 2 and lumbar vertebrae 3 and go around the aorta there. All right, just anterior and to the left, you'll find the esophageal hiatus, all right, right there, and right in the central tendon to the right of the vertebral column, you'll see the inferior vena cava. All right, so just to point those out, those aren't specifically about the abdominal wall muscles, but the right and left crus uh, are part of the abdominal wall muscles. So I wanted to point out how they make that connection with the hiatus of different structures in the coming from the thoracic cavity. All right, and then notice on this other picture here that we have attachment points on each of the ribs for the diaphragm because you want a completely enclosed cavity when we're talking about respiration, because there has to be a place to build up pressure. So even this hiatus right here and right here are filled with connective tissue so that whatever is above here, the thoracic cavity, forms a negative pressure space so that aids in the mechanics of breathing. These red things right here. I don't know where they came from. Another artifact that came in when I imported this lecture into the software I'm using. So they mean nothing, so don't pay attention to those red bars. So the blood vessels of the posterior abdominal wall. Important to pay attention to the abdominal aorta, and we're gonna get into this when we get to the digestive organs. But you have three major trunks coming off of the abdominal aorta. One would be the celiac trunk. All right, and the celiac trunk is just a short little piece right here, coming off the abdominal aorta, which then immediately branches off into other branches that we'll talk about next lecture. The superior mesenteric artery, all right, mesenteric going to the mesentery, so it's going to be involved with the intestines. And then the inferior mesenteric artery, same thing as the superior, involved with the intestines. All right, then you have your testicular or ovarian arteries, depending upon whether you are a biological male or female. And then the left renal artery and left and right renal arteries. So mainly those branches are going to supply blood to the abdominal organs. The veins that are associated with the posterior abdominal wall, of course, would be primarily branches coming off of the inferior vena cava, all right, such as the left renal vein, right renal vein, all right, your common iliac vein spreading out, and left and right common iliac vein spreading into each leg. Inferior vena cava, we mentioned that. And then above, your hepatic veins, which of course would drain the liver and the hepatic portal system. And then also running along the body of each vertebrae, you would have the azygous vein, which we've talked about previously, and then the hemiazygous vein. Azygous vein being on the right side and the hemiazygous vein being on the left side. For the lymphatics, one big thing of note would be the cisterna chyli, which is this big thing right here, and that cisterna chyli marks the beginning of the thoracic duct. So all of these pathways that you see going into that area, draining the lower regions of the body, would dump into the cisterna chyli, go up the thoracic duct, and then of course dump into the appropriate uh, veins in the shoulders, subclavian veins. All right. Notice that you have celiac nodes. You have all these nodes along the aorta, and all these nodes along the iliac arteries. And this makes sense because everything that's inside your digestive tract is coming from the outside. Plus, you also have flora inside of your gut, all of which are a potential invasion into the inside of the body. So you have all of these lymph nodes in this area to protect against any invading microorganisms that get out of the gut, whether they're coming from the environment with your food or whether they're coming from your actual gut yourself. So it makes sense you'd have a lot there. As far as so it's important to remember that. But as far as like physical exam or anything you'll be able to feel, you won't be able to feel any of these lymph nodes when they are inflamed or under disease conditions. So mainly just be aware of the cisterna chyli, and that marks the beginning of the thoracic duct, which we've already talked about. As far as posterior abdominal wall nerves go, you have these ganglia, which are collections of cell bodies that run along the aorta here. In fact, if you were to do a dissection and look down at the aorta, there would be a whole bunch of what looks like connective tissue sitting on the aorta, blocking some structures, and that would be part of this celiac and superior mesenteric ganglion, as well as sympathetic trunk ganglion, inferior mesenteric ganglion. You don't have to know about really any of those per se, but they are a collection of nerve fibers that are part of your sympathetic and parasympathetic nervous system that will control gut activities and blood flow to the gut. So, important to be aware of what these actually do. And of course, you see your sympathetic ganglion here on either side of the vertebral column that we've discussed previously. And then here we see many of the nerves coming out of the spinal cord, including those that take part in your lumbosacral plexus that go down to the pelvic region of the body, as well as to the lower limbs. And we'll go over those specifically more once we get to the lower limb and to the pelvis. So not too much else here that I want to point out specifically. If you look at here, these labels, and you can find some of the ones that we have gone over before. Of course, apply those nerves to the muscles or that we have learned before, so you can get a sense of what they're going to and where they're coming from. All right, so this is just a picture showing you the nerves coming from the spinal cord, going to ganglia, which are on the aorta. We have shown that in previous pictures, and then going directly to the muscular wall of the gut, just to kind of show you how those are all connected to each other. And then the dermatomes associated with the lower region of the body, lower region of the abdominal cavity. So we're talking about posterior abdominal wall nerves, supplying nerves to T10, 11, 12, L1, where T12 is. And we've shown these in previous pictures as well. So this right here would be your lumbosacral plexus, again, which we'll talk more about later. But, you know, all of the nerves, and the point of showing this slide, all the nerves that are in the abdominal region into the pelvic region are going to supply all of these areas with nervous innervation for either cutaneous sensation or for muscular contraction.